Good evening, everyone. Thank you for joining us for tonight's Dinner with the Doctors, Innovations in Joint Replacement. I'm Kim Schumann from York Hospital, where we have the distinct honor and pleasure of partnering with Dr. Akhil Sastry and Dr. Michael Morwood as we strive to offer the best technology in robotic assisted joint replacements. York Hospital Surgery Center was the first hospital in Maine to perform a Mako robotic assisted knee replacement surgery, thanks largely to the vision of Dr. Sastry. Dr. Sastry will present more about this breakthrough surgical innovation and the patient benefits of a robotic-assisted knee procedure. As the area's premier expert in Mako, as well as the first surgeon in Maine to perform this procedure, Dr. Sastry also teaches these techniques to other surgeons all over the country. He even recently achieved accreditation as the first master surgeon in robotic surgery in New England by the Surgical Review Corporation. Excuse me. Joining Dr. Sastry tonight is his esteemed colleague, Dr. Michael Morwood. Dr. Morwood specializes in computer-navigated joint replacement and trained at the University of Vermont College of Medicine, as well as Duke University for residency. Following the presentation this evening, we will do a Q&A, and I'll have a microphone that we can pass around so that everyone can hear your questions. Thank you again for joining us this evening, and I will now hand it over to Dr. Sastry.
Well, I want to take a quick minute and thank York Hospital, especially Jody and her team, for being able to put this venue together. It requires a lot of coordination, hard work, and so we really do appreciate it. Both Mike and I are extremely excited to be here to share not only our personal robotic experiences, but where we think joint replacement is going. And as far as robotics is concerned, we're just simply scratching the surface. I'd also like to take a quick minute and thank Stryker for helping sponsor this event. I think it's really important to be able to connect physicians with the patients in our community so that they get a sense of what we're doing in the hospital, because it's scary. And sometimes the unknown can be a little bit overwhelming, but hopefully we're going to be able to break down these walls for you and give you a better understanding of how robotics works. And most importantly, I'd like to thank all of you guys for taking the time out of your busy schedule to join us. I know that there are other places that you may perhaps want to be on a Wednesday night, so we do appreciate you making the commitment to come out and share your evening with us. And hopefully you'll get a sense of why we're so enthusiastic about where robotics is and where it will subsequently go. Now, before we get started about hip and knee replacement surgery, I want to share something with you. Now, I'm going to ask a few questions to the audience, so I hope that's okay. How many are you familiar with how cars are put together, right? So you're familiar with it? Absolutely. So when Henry Ford had his vision, what he did was he would literally create an assembly line. He'd have multiple people working on different sections of the car before the Model T was able to be put into fruition, and all of these different people were working together in order to put the car in place. So he did something revolutionary. But what was more revolutionary for Henry Ford was when he introduced robotics to manufacturing cars. The number of cars that would be able to be put together, the accuracy and precision of the cars that were put into place was unparalleled to the manpower that he was able to put together prior to the implementation of robotics. Now, how many people here got a chance to enjoy some Coca-Cola or some bottled water before we started tonight, right? None of the bottles are put together by human hands anymore. They're all put together with robotics. So whether it's putting cars together, whether it's manufacturing clothes, whether it's the food that we enjoy on a daily basis, once robotics touches that industry, it completely revolutionizes the way that industry performs. So now we've been doing robotics since probably the late 40s, early 50s. Do you know how many times robotics has failed in industry? Show of hands. Take a guess. You can't be wrong here. None. So that's absolutely right. So for over 70 years, When we've implemented robotics into a specific platform, not only has it demonstrated incredible staying power, it has completely revolutionized the industry. So moving forward, why would we think it would be any different when it comes to hip and knee replacement surgery? Knee replacement surgery and hip replacement surgery are so technical. So to be able to precisely place the implants within 1 millimeter of accuracy and take into account 1 degree of freedom in any direction we want should surely lead to a better result. And hopefully by the end of our talk tonight, you're going to see our vantage point. So let's get started. So the purpose of my talk is really to talk about partial and total knee replacement surgery. These are my disclosures. I consult for Stryker and Medtronic, predominantly for education. So when we're talking about arthritis, you're not alone, right? In the United States, as it stands, about 40 million people have already suffered with some affliction of arthritis. And we anticipate within the next decade that the number is going to increase to about 60 million. And when we use that term, arthritis, under that subcategory, there's multiple variations of arthritis. There's the good old-fashioned wear and tear, which your doctor may refer to as osteoarthritis. There may be an inflammatory component, where for some reason people with autoimmune diseases have certain antibodies that attack their own cell lining that causes cartilage to deteriorate. There can be a situation where, unfortunately, someone's involved in an accident, and then subsequently that accident leads to cartilage damage. And then their final type is something called avascular necrosis, where the blood supply to the cartilage becomes compromised. But nevertheless, regardless of which type of arthritis you have, ultimately, it doesn't matter, because they all lead to a deterioration of cartilage, and how you get there is irrelevant. What the underlying cause is also somewhat irrelevant, because unlike your skin and like your hair, at least for me, for a few more years, I hope, the hair has the ability to regrow, the skin has the ability to regenerate, the cartilage doesn't. So when you develop cartilage damage, regardless of the reason, it does not have that ability to regenerate itself. And that's the reason why people suffer from pain, stiffness, and they walk with a limp, and it really starts to impact their day-to-day quality of life. So like any good surgeon that sees you for the first time, we would always try to implement non-operative modalities first, whether it's a combination of over-the-counter anti-inflammatory medication, weight loss, physical therapy, a combination of different injections. But unfortunately, all of these are temporary solutions to a permanent problem that you have. So inevitably, you're going to have a joint replacement. As it stands in the United States, we do about 300,000 hip replacements annually and 700,000 total knee replacement. And assuming that the projections hold from the previous slide that I showed you, from 43 million to 60 million, the anticipated growth in joint replacement surgery just in the United States is expected to be about 850,000 hips annually and about 1.4 million knee replacements. So that's a lot of surgery. So even if you feel like you're alone in this fight, you're really not. And there's a very good chance that if you haven't encountered someone who's had surgery, you very well soon will. Now, arthritis of the knee is very different than arthritis of the hip, which Mike is going to educate all of us on. When we talk about the knee, I always like to segment it into compartments. There's an inside compartment called the medial compartment. There's an outside compartment called the lateral compartment. And there's a compartment under the kneecap called the patellofemoral compartment. Now, in certain scenarios, you may lose cartilage in all three compartments. But in many scenarios, the cartilage loss will be limited to one section of the knee. And when you have cartilage loss limited to one section of the knee, we have to make a decision of whether or not a partial knee replacement is better than a total knee replacement. Now, before we get into some statistics about the partial knee replacement, this is Medicare data. Our statistics at Portsmouth and York Hospital are far better, but I'm not going to talk about anecdotal experiences. We're going to kind of limit, since we're all technically scientists here today, we're going to try to evaluate and critically make a determination of whether or not one potential procedure is superior to another. So typically, according to Medicare data, an average person will stay about 3 days in the hospital. The surgical scars tend to be a little bit longer. But more importantly, the average return to work is anywhere from 6 to 10 weeks. So that's a fairly long interval before somebody can go back to the things that they want to do. And all of this data is based on manual total knee replacement surgery. We haven't even scratched the surface as far as robotics is concerned. But when we talk about partial knee replacement surgery, we're talking about limiting one compartment of the knee. This can be done as an outpatient surgical procedure. The scars tend to be about half the size. And more importantly, the return to work is about 4 weeks, and most people are comfortably driving within 10 to 14 days. So it's a dramatic difference for that initial short-term recovery when we look at the two subset of patients. Now, in the United States, as it stands, only 75,000 of the 700,000 knee replacements are being done with a partial replacement. So the question that we all have to ask ourselves, are the majority of candidates not good partial knee replacement surgery candidates? Or are the surgeons not critically looking at the x-rays and performing proper examinations to determine if someone is a good partial versus a total knee candidate? And I think that that's an important question to ask, because if you look at other developed nations, England, Sweden, Switzerland, Norway, Australia, all of those countries have something called joint registries. And unfortunately, in the United States, we're a little bit lagging behind, but hopefully within the next 6 to 10 years, we will also follow a similar pattern. For those of you who are unaware, what a joint registry is regardless of which surgeon does a replacement, it will automatically be put in a data bank. So if there's any concern of that prosthesis, when we're talking about tens and thousands and hundreds of thousands that are being done, the database will identify and flag any parts that are prematurely failing, or subsequently you can track how well the parts are doing. So that's really good, important data, so that can be shared and disseminated into large groups of surgeons, and obviously the population is going to be better taken care of because we can capture any outliers. But if you look at those countries, partial knee replacement surgery is being done anywhere from 25 to 40% of the knees that are being replaced. That is far less than what we're currently doing in the United States. So the question that we have to ask ourselves is why? And I really think it has to do with our surgical training here in the United States. And believe it or not, technically, a partial knee replacement surgery can be more difficult to perform than a full knee replacement. And most importantly, a partial knee replacement is far less forgiving, and it's more likely to fail if not done properly. So partial knees have actually been done since the early 80s in England. It was developed by an orthopedic group in Oxford. And when properly trained, and the surgeon has a good understanding of how to do it well, the survivorship for a partial knee is about 90%. That's very similar to a full knee replacement surgery. And according to the Oxford group in England, at least 40 to 50% of candidates with arthritic knees should have a partial knee done rather than a full knee. Now, if you think that's on the higher end, certainly a conservative number would be 25%, which is still 2.5 times the number that is currently being performed. But as I had mentioned before, partial knee replacement surgeries require incredible accuracy by the surgeon. And it all has to do with how we've been putting it in. And when we're making a cut on the bone in order to replace a hip or a knee, we require something called instrumentation. So the instrumentation is put on the patient's leg, and we're literally looking at it from the front and looking at it from the side and making a determination of what angle we're making that cut in. Now, certainly surgical training, surgeon experience, previous positive and negative experiences will allow that surgeon to more accurately and precisely place the parts. But this is essentially what we're looking at. But the problem is, whether it's your knee or my knee, we live in a three-dimensional world. So it's high time that we participate in the evolutionary process and we don't get stuck into looking at things that are only two-dimensional. Now, if you look at the evolutionary process of joint replacement surgery, we all started with something called a static plan. So that means we got a plain x-ray, which you still get in the office, that gives you an overview of where the cartilage loss is. Then we subsequently transitioned over to something called PSI, patient-specific instrumentation. You may or may not have heard of it. Companies like Conformis make a molded knee. There are other companies like DePuy and Biomet. They make molds where they allow the surgeon to pin it into place in order to make the cuts. So that improves our accuracy, but it's still not getting us to where robotics can do. And one of the analogies I always like to draw in my office is think of the x-ray as a flip phone, patient-specific instrumentation as a BlackBerry, and robotics as an iPhone. It's literally a computer that allows you to make intraoperative adjustments so the implants are customized to fit that particular individual perfectly. And that's really what Mako Robotics is all about. So this is what the machine looks like. Believe it or not, it's actually a larger machine than people can imagine if you haven't seen it live. It's about 900 pounds. And the way that it works is it is in constant communication with the extremity that we're operating on. And it's based on 3 core principles. Something called a preoperative CT scan. So if you're coming in to see us to have a replacement on the knee, a CT scan will be done of your particular knee. That CT scan allows us to create a 3D anatomic model. So on a computer, we can start to play with the operation and get a sense of what size the parts should be, what alignment the parts should be, are there any anatomic variants to that particular individual? So up till now, it's very similar to what some of the other systems can do. But the differentiating features are the next 2 steps that I'm going to talk to you about. The day of your surgery, when you're asleep, pins will be driven into your bone that have sensors. The sensors will send and receive a signal via infrared and optics to the robot. The robot will ask us to identify surface landmarks on the bone itself, and once it identifies the surface landmarks, it will take our plan that we had based on your CT scan and superimpose it live on the knee or the hip. And as I'm bending and straightening the leg, it will tell me in live time if it's too loose, if it's too tight, if it's just right, if it's tracking properly. And all of those metrics are obtained before the saw blade is actually taken to the bone. So then we'll reconfigure the implant to make everything as close to perfect as possible. And there is a variability of 1 millimeter of error, which is about 5 to 7 eyelashes, so it's fairly accurate. And then we'll deliver the robotic saw into the surgical field, and it will not allow us to deviate from the plan that we've set into place. So that's what we're talking about. We're talking about patient-specific preoperative planning, intraoperative adjustments necessary based on what the tissues are doing around that particular joint, and then obviously executing that plan perfectly with the robotic saw. So I'm going to give you a quick overview of how a partial knee replacement works. I think this video will do it justice. So that's what the machine again looks like. And that's the double jointed arm that creates multiple directions of freedom for us to do the operation. And those are what a partial knee replacement parts will look like. So this is the first time at any point in surgery where we get a chance to evaluate the joint at 360 degrees of freedom. We've never had that capability to do that because all of the instrumentation to make our surgical resections were based on 2D models. This is the first time where we have a 3D model that really allows us to get that proper assessment and evaluation. So what now we're showing you is how one person's soft tissue may feel a little bit different than in others, but this particular individual has certain positions of the leg where it feels a little bit too tight and a little bit too loose, and we're literally reconfiguring the implant live to account for that based on what it's doing at 30 degrees, 60 degrees, 90 degrees, 120 degrees. So those adjustments have never been performed prior to robotics. So that allows us to precisely place the implants in a perfect spot. And then we'll bring in the robotic arm to take out that diseased cartilage very precisely so that we can put the parts in place at the exact desired spot based on the intraoperative adjustments that we've made. So that kind of gives you the overview. So obviously, it's a smaller incision, less surgical dissection, less violation of tissue, and at this stage, closer to 100,000 partial knee replacements have been performed in the United States alone with robotics. God bless you. Overall satisfaction rate for patients with a partial knee is 92% in comparison to about 70% with full knee. Now, this is based on manual data. Robotics is higher. And they have actually technically a lower revision rate. That means fewer patients are coming back to the surgeon to have it redone because we can customize it so well. So now what happens to the people that have cartilage loss involving more than one segment of the knee? Unfortunately, in that scenario, the proper operation is to do a full knee replacement. But as I had said to you before, sometimes you're not necessarily signing up for what you think that you've signed up for. When you do a manual full knee replacement surgery, there's at least 1 out of 5 patients that seem to be unhappy with their knee replacement. And it's a combination of reasons of why that person is unhappy. They get stiffness, they get pain, they have poor function, they develop something called arthrofibrosis, where they have scar tissue that forms in the knee that prevents the knee from bending and straightening in all the way. And a lot of it has to do with how we position the implant. This is the first time that we've been able to control for the implant in the coronal position, which means straight down, in the axial position, which means rotation, and then the sagittal position, which is the profile view. So by being able to properly coordinate all 3 views for that particular individual, we run into fewer scenarios of where the implant is quote unquote too big for the bone, or the implant feels more unstable. A lot of that has to do with technical error. And now we have a tool and device that will allow us to mitigate those errors and precisely place the implants for that particular individual. The other scenario that can happen is, remember, when we're doing manual knee replacement surgeries, we're making the cuts and then deciding if it's proper or not. That's completely opposite and counterintuitive to everything else we do in life. If I asked you to hang a painting, right, you're going to use a leveler or something. You're not going to simply put a hole in the wall, put it on, and then make a determination that it's crooked. That's absurd. But essentially, that's what we're doing with manual knee replacement surgery. Now, we're able to ascertain that proper information and avoid these technical errors. What this is illustrating here is that there was too much bone that was taken out on the distal part of the femur. And now, in order to avoid it being loose when the leg is completely straight, they end up under resecting the part in the back of the femur so they feel tight when the knee is bent. So these are scenarios that we don't encounter anymore with robotic surgery. So as the number of knee replacement surgeries are increasing, we have to take into account how can we better take care of our patients? And there's a really good match with technology and implants that have demonstrated really great staying power. I had mentioned the joint registry before. This particular implant that's been done with robotics has had the lowest revision rate of any other device according to the Australian registry. So that means fewer of these replacements are redone for that particular reason. And I think it's all based on accuracy, precision, and intraoperative adjustments that allows our patients to recover and heal more quickly. So with that being said, I'm going to give it over to Dr. Morwood, and he'll take over and talk to you a little bit about hip replacement surgery.
All right. So we'll get swapped over here for a second. So I think we're good. All right, perfect. So I think we're loaded up. So thank you everybody for coming. Thank to Dr. Sastry. It's a great talk. He's the smart one. I'm just the good-looking one. That's why they brought me. But just kidding. So we'll talk a little bit about a couple of things. We'll overlap. Just real quick slide on me. So I did my training in Vermont, was where I went to medical school, and then I did my residency at Duke in North Carolina, and then I went and did a trauma fellowship. So part of my job is what I do is trauma surgery. And then after I did my trauma fellowship, I went and did a hip and knee replacement fellowship. So I kind of do a little bit of both, and it's a good mix to have, I think. So I don't have any disclosures. So a couple of different things we want to touch on. Obviously, a little bit is going to overlap with Dr. Sastry's talk on knee, because a lot of arthritis or arthritic pain, there's overlap between the two for both hip and knee. But we'll go over a couple things, including kind of understanding just generally what is hip pain, what are the treatment options, a little bit about what total hip replacement surgery really is, and then we'll touch on the Mako. So joints are everything, all right? Everything you do, every activity you do involves your joint. Walking, bending, turning, work, school, play, everything is going to involve your joint. We walk, we're upright, that's what happens, we use them. So when the hip or the knee becomes injured, pain, this can severely limit your activities, can severely limit your day-to-day activities, including, things getting around the house. People say, I used to be able to walk to the mailbox. I can't walk to the mailbox anymore. Used to be able to play with my grandkids. Can't get down and play with my grandkids anymore. These are all things that we view as surgeons as things that we can help with because we have solutions for these types of pain. So a lot of times people come to the office, they come to see us in the clinic, or they come to the talks. They have specific questions in mind. So one thing we definitely are interested is to get out there, and any questions that you have, feel free to shoot them up. But a lot of times people come in specifically and say, is this my hip? Is it my hip? They point, to here. Is this my hip? Is this my hip? I'm feeling pain deep down there in the groin. Is it a hernia? Is it a muscle strain? So it's a little bit to us to try to figure that out, to tease that out as to what is actually occurring. And a lot of time, pain in the buttocks, pain in the lower back, pain in the groin, that's hip pain. We know the hip joint itself is in there, and so that's a lot of times it's coming from the hip joint. Another question is, I don't always feel pain. Is it normal? Is that what everybody with arthritis feels? And sometimes that can be. So pain that you have after sitting in an auditorium for a long time, or pain when you get up for the first step in the morning. Those are very common things that people have for symptoms of arthritis. Pain from arthritis and joint degeneration can certainly be constant. So if you have a very irritated, inflamed hip or knee, that can be constant. It can also come and go. Sometimes people say the weather changes, and there's some physiology behind why that actually is. But my arthritic hip always tells me when it's going to rain. It's actually a relatively common thing we hear. It can occur after movement or after a period of rest. So if you sit in an auditorium for a long period of time, you go see a movie for a long period of time. First step, a lot of times say, it takes me a little while to kind of get moving, get going a little bit. Can be located in one spot or many parts. A joint is a joint. A joint in the finger can be arthritic. A joint in the hip, a joint in the knee, a joint in the ankle. A lot of times these are multifactorial or multiple joints can be involved. So what is the normal hip? We'll start there. Hip is a ball in a socket. In the end of the day, that's what it is. It's a ball in a socket. You have a socket here. This is part of your pelvis. And you've got the hip here. There's the ball. That's all it is. It's a ball in a socket. An arthritic hip involves that ball and socket joint. So the cartilage gets worn away. The body starts putting bone spurs, bone chips, bone fragments all over the place. The tissues around get irritated, inflamed, arthritic. And this is what an arthritic joint looks like. What does it look like on x-ray? Well, here we go. So there's a normal hip on the left. We look at three things, really. We look at that space between the ball and the socket. There's the socket, there's the ball, there's space there. That's where the cartilage lives. We can't see cartilage on an x-ray, but you know it's there because you're getting that space. You also have a nice clean-looking top of that socket. There's no hazy, bright white stuff like you see on the other side. Transition over to this arthritic hip. That is a square peg in a round hole. That head has become deformed. That cartilage is being lost. The bone is becoming evernated. You have no joint space left. You've got all of this sclerosis. That bone is seeing a tremendous amount of stress now. There's no cartilage buffer. And you're getting big cysts, big fluid-filled pockets in the bone. You can imagine how painful that is. Dr. Sastry touched a little bit on this. What is the common causes of hip pain? Far and away, wear and tear or osteoarthritis is certainly the most common cause of arthritic pain. We do know this. It does involve a breakdown of both the cartilage and the soft tissues around the joint. The tissues around can become weak, can become frayed, and it leads to a little bit of a kind of a cycle that, you get a little bit softer bone, a little bit more degeneration, a little bit softer, more degeneration. It kind of leads to itself. 27 million Americans. We also know, all arthritic causes, it's just increasing. It's going up in scope. When it comes to arthritis, you're not alone. This is a slide kind of illustrating that again. This is one of the more common things, especially as orthopedic surgeons, we see this all the time, arthritic degeneration and disability. So what are the goals of treatment? In the end of the day, this is a quality of life issue. This is something we want to make life better by improving pain, improving the dysfunction that's caused by it, increasing motion, and improving strength. Because the last thing we want to hear is, for the last 5 years, I haven't been able to play tennis anymore. I had to give up golf. I can't get down and play with my grandkids on the floor. These are things that we want to target, that we have effective strategies for, that really can make your life better. I always like to use this analogy. It's a ladder approach to treatment. You always got to start at the bottom first. Non-operative therapy should be the mainstay in the beginning. Pain medicines, anti-inflammatories, over-the-counter, ibuprofen, Tylenol, joint injections, whether it's cortisone or gel shots or other modalities. There's all of these things that we can try to get you there without surgery. Physical therapy can be helpful. We got some PT guys here in the back. We can talk about physical therapy to keep the muscles strong around the joints, to get your gait correct, to try to be as normal functioning as you can prolong the life of your joint. Diet and exercise, we all know, can be very, very helpful. Sometimes walking aids, every once in a while, a cane, a crutch, something to at least get you over the hump can be helpful. Medications we touched on a little bit. Anti-inflammatory is kind of the mainstay. This is, in the end of the day, this is an inflammatory process. Whether it's from wear and tear arthritis, or rheumatoid arthritis, these anti-inflammatory medicines can be quite helpful. And then the top of the ladder, we come into joint replacement. Exercise may help joint pain. So we do know that low impact aerobic exercise, the joints love motion. They don't like heavy pounding. They don't like the running. They don't like deep knee flexion, deep squats, things like that. But pool therapy, recumbent bike, elliptical machine, these are all great modalities for keeping your joints nice and healthy and strong. So then what is hip replacement? It's honestly a very basic thing. It's a ball in a socket. We replace the ball, resurface the socket. In the end of the day, that's what it is. It's simply this portion gets resurfaced with a metal shell. This portion gets replaced with a metal ball. And there's a piece of plastic in between that it rotates on. It replicates. That's the mainstays. We're trying to replicate normal joint. restore function, restore offset, restore your leg lengths. A lot of times hips become short, legs become short because the cartilage wears away. So when the cartilage wears away, the leg becomes short, your gait gets thrown off, you limp, leads to itself. So a little bit, again, how it works. We just talked about that. Ball in a socket, replace that ball and replace that socket. It should be as easy as that. Sometimes it's not. It's a little bit more tricky. This is a little bit of an illustration kind of as to how that goes. Again, kind of peeling back the layers, you'll see here's the ball being removed, the arthritic ball being removed. There's the resurfaced socket portion, the piece of plastic spacer, the stem, the pin going down the leg, the new head. There you go. Sometimes it's a little bit of a misnomer. A lot of times people will come in and say, hip replacement, or knee replacement, do you take my knee, throw it out, put a new knee in? It's really a little bit of a misnomer. A lot of it is a resurfacing. You're just removing the diseased portions of cartilage and bone and replacing them with metal. Certainly more common than a lot of people think. 300,000 hip replacements, this was discussed a little bit earlier. 300,000 hip replacements are performed each year in the United States. And then how can we make it perfect? This is, in the end of the day, our job, again, is to make this a normal feeling joint. We want to restore certain things like offset, so where the hip is in relation to the outside of your body. We want to restore your leg lengths. So if you have a short leg, a long leg, something like that. These are all things that we as surgeons are stressing, and it's incredibly important to make that happen. So that's one of the things that the Mako Total Hip, again, similar, analogous to the knee. We want to have a way to do this perfectly. We don't want to be guessing. We don't want to leave the operating room saying, probably okay, think it's going to be okay, I think we got it there. We want to make it perfect. So how does it work? A plan. All begins with the CT scan. Similar to the knee, here's a CT scan of the pelvis. I know exactly what your bones look like. I know exactly where your socket is. I know exactly what the leg lengths are. I know exactly what the head looks like. CT scan gives me that 3D virtual model that we bring into the operating room. And this is what we're looking at. So this is an actual CT scan where the green outline is going to be where our new hip prosthesis is going to be. I can see exactly how to orient that hip prosthesis. This is three-dimensional space, but we're able to utilize this preoperative CT scan to see exactly where the implants are going to go, exactly how they're going to fit. And this is honest, this is what it looks like. So that's me, and that's the computer screen that I'm looking at. This is a knee specifically, but it's the same thing for the hip, where we're now going to take a tracker and paint essentially the knee in real time, or the hip in real time. The computer is going to see that and determine this is exactly what I think it looks like because of my CT scan. It's going to match the two up. And it gives us a real time, in the operating room, three-dimensional model of what those bones look like. And it allows us to place an implant in perfect position. This is a post-op x-ray of mine, a patient I just did. Leg lengths are equal, implants are fitting perfectly. And I think it's going to be really a game changer in terms of being able to use this new information. It's not guesswork. We leave the OR. For me, the nicest part, leaving the OR knowing exactly what I plan to do is what happened. That's the best thing. A few misnomers, again, about Mako, robotics, computer assistance, all of that sort of thing. The robot doesn't perform the surgery. The robot doesn't make decisions on its own. And the robot doesn't do anything I don't tell it to do. So the best analogy I've heard before, it's kind of like a tractor beam. It puts you in a zone, doesn't let you deviate from that zone. You try to go outside the tractor beam, it shuts you down. That's what the robot does. It doesn't make a decision for you, but you make the decision, and it keeps you honest with that decision. 60,000 Makos since 2006, and over 16,000 just in the last several years. So this is a technology that's picking up very quickly. When we talk about hip replacement, we talked a little bit about why we do it. Here are some realistic physical activities: walking, swimming, golfing, tennis, hiking, low-impact sports. Skiing is huge. We all want to get back to skiing. We all want to get back to doing some activities of daily living and other fun activities, because in the end of the day, this is a quality of life thing. It's not anything you have to have, But when we can identify things that we can help with, live life, improve life by removing that pain, that disability, that dysfunction, that's what really, in the end of the day, that's what we're here for. Return to driving, 4 to 6 weeks. Hips are certainly a little bit more forgiving, especially when you can put the implants in perfectly and get it exactly where you planned it and exactly where they need to be. I included this slide. So this is from the medical journal of The Lancet. This is in 2007. Now, this is a medical journal. This is not a surgery journal, but to be able to have an article labeled "The Operation of the Century, Total Hip Replacement." This operation was deemed the operation of the century. Before we had hip replacement, people had significant dysfunction, terrible dysfunction, disability from hips going bad. And this operation really has revolutionized a lot of activities, a lot of people's lives. And to be, again, named the operation of the century in a medical journal was pretty prestigious. Another one really wanted to bring together is, a lot of times people come and say, my hip is killing me, but I'm too old. Somebody told me I was too old. My doctor told me I was too old. This is an article that came out, or that was getting written when I was down at Duke, and by, again, some of the medical physicians. These are rheumatologists. These aren't surgeons. There's no surgical bias in this. These are medical physicians who looked at total hips on functioning and outcomes in the older population. This is a quote from their recommendations. Seniors with arthritis who undergo hip replacement are twice as likely to show improvements in functioning and ability to care for themselves. And then furthermore, they made a point to say no age limit on the benefits. So everybody's a little bit different. Every case is a little bit different. There are, risks, benefits to surgery, of course. But one thing you want to have that conversation. You don't want to be precluded from potentially having a great pain relief operation for just age alone. One more thing I wanted to bring up a little bit. There's multiple ways to go about doing a hip replacement in terms of just pure approach. So obviously the hip is here. I can go from the front, go from the side, go from the back. Multiple studies have been looking at it. There's tons of information out there in terms of what's the best approach and how to do the operation. I think traditionally, the traditional hip approach has been kind of posterior lateral approach. Tried and true, it's worked well. But there's a little bit of downside to it. So it's a muscle splitting operation where you actually have to split the muscle a little bit to get down to the hip. You usually have to follow strict hip precautions afterwards. A lot of times we don't want you to flex the hip too much or internally or externally rotate it too much. And it can make activities such as getting into and out of a car, getting up from a low toilet seat, climbing stairs, a little bit more challenging, especially early on. The approach, my preferred approach, and Dr. Sastry's preferred approach, actually, so it's a direct anterior approach. You'll hear that's kind of it's a buzzword lately. But we like the approach a lot because of multiple different things. Leaves your muscles undisturbed, so it's a muscle interval. So we actually go between muscles, open that up, do the hip replacement, close the muscles, no muscle splitting. Typically, there's no hip precautions afterwards. You can flex your hip as much as you want. Studies have looked at this, overwhelmingly show a little bit faster recovery, a little less need for post-operative therapy, and improved immediate pain relief right after surgery. So I think it's a great operation. It's a great approach for a lot of people, and we certainly are very excited to kind of bring it to our communities. Just real quick, this is a little kind of what I'm talking about here. Here's the kind of anterior approach, side, and a little bit bigger incision on the back and the posterior approach. We can certainly go over that too if you'd like a little more information. This is it's your move. That's my funny slide, I guess, if you want to talk about it. Are you less active because of hip pain? Does hip pain keep you from doing things you want to do? And is hip pain affecting your ability to walk upstairs, play with your kids and grandkids, get down on the floor, do your activities, daily living, go to the store, grocery shop for more than 10 minutes without having pain? These are all things that we know, we talk about as having a potential very good solution. And hip replacement, I think, is a phenomenal operation and can be especially very, very helpful for a lot of folks. So this is my last slide. Just was throwing this out there real quick. This is Operation Walk. It's a volunteer service that I been a part of for a little while. This is a map of El Salvador. We went to El Salvador and we do volunteer hip replacements for folks. Last year we went down. We did 74 hip and knee operations in 4 days, and that was about 1/10 of the wait list. So there were 750 people on the wait list. So unfortunately, we can't get to everybody, obviously, but we get to a ton, and it's a great organization if anybody has any more questions about that. So that's it. I think we'll open it up for some questions.
When do you do the pre-op CT scan? Is it the day of surgery, a week before, a month before?
Yeah, it's at some interval beforehand with a couple of days' notice, at least to get the preoperative plans, typically 10 to 14 days or so. Gives us enough time to plan with the company and the robot and everything to get that plan correct, exactly what we want it to be.
So are there a variety of different sizes of heads, or there's like a few different choices?
Yeah.
How variable and specific are they to the individual?
Yeah, incredibly, really. I mean, if you look at the socket portion, for example, there's millimeter increments anywhere from 44 millimeters all the way up to 64 millimeters. I mean, you can march up and get exactly that size, exactly what you want.
CT scan would give you that information.
Exactly. Yep, to the millimeter. Yes, sir.
I'll speak hopefully loudly enough. With any surgery, of course, there's risk, as you've pointed out. What you haven't said is anything about infection, which either with traditional or with robotic surgery. Just very briefly on thoughts on infection. And also what I've read, a 15 to 20 year life expectancy on various joints. So would it be best perhaps to work with those other modalities of NSAIDs and so forth until you get to a point where you really feel like your life choices are being limited, and then wait for that to do surgery? Or does the joint still keep deteriorating, which then makes the surgery more complicated?
Sure. So to the first question, infection risk is low. I usually quote about 0.5% to 1% or so. In most, you're going to look at an overall population look. We do everything we can, obviously, to limit that risk. You get antibiotics before the operation. You get antibiotics after the operation. It's a completely sterile field, sterile technique. We use everything we can to limit that risk. It's not really implant specific. It's not approach specific per se. There are some technical factors from a surgical standpoint, how long the operation takes, how long the wound is open for, things like that. But when you're facile with the operation, you limit that tremendously. Second part of your question. So historically, when you look at either a hip or a knee operation, the metal is not the part that wears out. It's been the plastic. So when we talk about hip replacement or knee replacement, if I can find, here's a metal piece, and then there's that plastic piece in between. Historically, again, without infection or loosening or whatnot, the metal pieces never wear out. It's the plastic. Around the year 2000 or so, the plastic changed dramatically for the better. Before 2000, the plastic lasted about 10 years. Since 2000, the plastic is still going. So it's been 20 years now, and results are very good in terms of wear of that plastic. The other part about it is that, again, if the metal parts aren't wearing out and the metal parts are placed correctly and they're anatomically working well, the operation to swap the plastic out, if that's the bad part, is much smaller than the operation to put everything in. So this is a long-winded answer to your question, but essentially I would recommend you try everything non-operatively first until you come to the decision yourself, is the quality of life that I'm having right now not where I want it to be? And that's a different answer for everybody. It's a different answer. Some people say, if I can take a couple ibuprofens a day and feel good enough, I'm happy. Some people say, this is getting to the point where I can't sit for more than 10 minutes. I need something done. I would make that decision before I worried about the revision.
And the last part to my question was, if you do wait, does the joint continue to deteriorate and then cause a harder surgery later on?
So two parts. Yes, it will continue to deteriorate. We know the natural history of arthritic change is a progression downward as that cartilage continues to wear, as the body continues to form more bone spurs and things like that around. The joint itself will wear itself out. There's probably a tipping point where it becomes very, very challenging. We do, we do operations that are technically easier than others. But that won't be, I would never tell somebody you should have a hip replacement now because it's going to be easier for me. I think if it's the right time for you, it should be the right operation. Yeah.
It's my understanding that prior to the invention of this machine, there was still a posterior and anterior procedure for doing a hip replacement. And the anterior was much less invasive. So my question is, how much less invasive is the robot compared to how much less invasive a regular anterior procedure is?
Yeah, great question.
I do have a second part to the question, too.
What's that?
I do have a second question as well.
Sure.
Let me get that out there as well. Assuming you have a successful surgery, that you heal properly, can you then go about living your life the way you did prior to your first inkling of having arthritic problems? Is there a limit to how physical you can get? If you're skiing and you fall on that hip, does that ruin the whole thing? Or is it just like a regular hip?
Yeah. He's putting our feet to the fire here. This is good. All right, so the second part was, you'll never have an 18-year-old hip or knee again. This is an operation for quality of life, to improve your pain, improve discomfort. I think recent advances are making it so, yes, you can start living life like you had before. I honestly believe that. 30 years ago, we did a hip replacement because it was either you're essentially crippled from disability or your pain is better. I think nowadays we're doing them to get people back to living life. So I don't restrict anybody from anything, personally. There's some debate on that, but I did a lady the other day who said she wanted to run marathons again. I didn't recommend that, but to me, I think getting somebody to do things that they want to do, and I think we have the capability, the tools to place these implants effectively enough to withstand things like that. Skiing, tennis, light jogging, things like that. I firmly believe we have the technology now to be able to do that. And then I think the first question was the kind of invasiveness. Yes, not as much in hips. Anterior approach to a hip is much less invasive than a posterior approach to a hip would be, just by default. I would say robotic knee is much less invasive probably than a standard knee, because in a standard knee, the exposure you need to get, the releases you need to do to see what you need to see to get the operation done proficiently is probably a little bit more. So I think it certainly has been borne out a little bit in our literature that says, yes, the invasiveness or the amount of things we need to do in the joint is a little bit less with the robotics. But you can go skiing if you want. Quicker. It's all about that plastic, really. I mean, it is. It has a finite amount of time to it. But I said to her, if you're going to sit there in the chair and not move it at all, it'll last you 30 years. If you run, maybe it lasts you 20 years. But you had 30 years of doing nothing, 20 years of enjoying your life. For me, I mean, these are quality of life operations. Our goal is to improve, what you want. You want to get back to doing what you love to do. That's what we're here for, to be honest.
I have a series of questions. I hope you can bear with me.
Sure.
First of all, do you analyze where, for example, pain is, you said immediate pain relief. Does that mean pain will definitely go away
For hip, for knee, what?
for anything? For hip, knee?
Sure.
So after the operation, you should not experience any more pain?
No, so they are operations. You will have surgical pain. Knees and hips are a little bit different in terms of how folks do post-operatively. I'll tell you, just since I'm doing the hip talk, a lot of people will say, I woke up in the recovery room and that groin, that achy pain was gone. I had surgical pain, of course. You know, we do everything. These aren't pain-free operations, but we do things to make you comfortable. But a lot of times people will say that nagging, gnawing, grinding pain is gone.
So it should subside, but doesn't necessarily go to zero?
Correct.
Okay. And do you analyze, for example, let's say someone doesn't know if it's their hip, their knee, or their back that's causing problems? Do you analyze that before and recommend which surgery you need? 100%. 100%.
100%. Yeah, and that's one thing, as orthopedic surgeons, it's our job to kind of identify what is the problem, what's the best way to treat it. So if people come to me for a consult hip pain, and I notice, I'm trying to be less formal. People come to me and say, I'm here for a consult for my hip, and I look at their x-ray and I listen to their story, and they're pointing out a different place, and they say, oh, it's my hip, it's my hip, it's my hip, but I've actually noticed it's your back. It's your lumbar spine. You've got spinal stenosis. You've got nerve pain that's coming into your leg. Those overlap quite often, actually, and so it's definitely our job to nail that diagnosis.
How long is the average surgery for each?
It takes about an hour.
An hour.
Yeah.
And that's true of the knee as well? About the same? And how about the recovery process? What would you expect? How long in recovery, like what would you do? Physical therapy for each?
Sure. So for us, for both of us, actually, our post-operative rehab protocols are fairly similar. For hips, I'll just take hips. We have physical therapists come to your house for a little bit of time. It's either a day surgery or a one night in the hospital stay. And then we get therapy to come to you. Name of the game really for hips is just getting strong, getting walking. I'd say by about 6 weeks, you're back to doing most stuff that you want to do, especially with an anterior approach hip.
And how many surgeries have each of you done?
I've been in practice for a while, so it's a little different. I probably did about 1,500 plus anterior hips, and probably over 1,000 robotic knees. Done quite a few.
Yeah, and I'll tell you, I haven't kept track per se of overall for the last 7-8 years, but the one thing I did keep track of was my trauma year. I did 850 trauma cases that year, so that was kind of a good year.
Thank you very much.
Yeah. Yes, ma'am.
Muscle, but in a knee surgery, do you cut into the muscle, or what happens?
Yeah, so again, there's a little bit of there's different
Right.
ways to go about those surgeries, the knee, and I can let Akhil talk about that, but the knee and the hip, you can both do different approaches to. One approach to the knee is called a subvastus approach to the knee, where you actually take the muscle and just release it off the side wall, do your operation, then put it right back. No cutting into the muscle or the tendon. The other approach is you make an incision through the quadriceps tendon and then repair the quadriceps tendon afterwards. That's the most common way to do it. And then in the hip, the one in the back, you split the muscle a little bit. And then the one in the front, you don't have to split the muscle.
Thank you.
Can you talk at all about the cost of this, like the using the Mako robotics versus not, and how insurance deals with it?
She's looking at me, so I'm assuming you. So there's actually no upcharge for robotics. It's a CPT code. CPT codes are you're doing the surgical procedure based on what extremity you're operating on. So there's no upcharge there. There's no upcharge for the hospital. This is more of a quality measure and metric. And so the concept is a little bit different. There is a preoperative CT scan. So depending on your insurance, there may be a deductible that has to be met for a preoperative CT scan. And if it's Medicare, it doesn't matter.
Do you see a difference in edema in the knee replacements, a traditional knee and a robotic knee?
Yeah, so what we did is we looked at our last 40 manual total knees, and we looked at our first 40 robotic total knees. That might be indicative of what type of manual surgeon I was more than what the robotics is, but I would like to think that's not the case. We found that they do have less surgical pain, less swelling, faster recovery in terms of range of motion, and they hit all of their ADLs more quickly. ADLs are activities for daily living. So that was a nice way to look at my own work and see if it's just sort of a subjective improvement or if there's some sort of objective improvement. So I thought there was some value there. I think one of the reasons why they perhaps could have a little bit less swelling and better improvement of pain has to do with something called soft tissue stripping. So in my talk, I had mentioned that when you're doing a manual knee replacement, you're cutting the bone and then you're making the assessment. Versus robotics, you're making the assessment and then cutting the bone. There's also another variable with knee replacement surgery. There's a certain surgical approach in order to gain access to the knee, and it involves soft tissue stripping. It sounds violent, but it's basically how we gain access to the joint. As you become more versatile and comfortable doing robotic-assisted knee surgery, what I've found is the amount of soft tissue stripping off of the bone itself has gone down precipitously. And that, in turn, I think has led to less swelling and better range of motion. Because at that interval, a patient is not going to be able to tell, wow, this is perfectly placed on the right knee, and the left knee, which was done manually, was not perfectly placed. What they're going to perceive are how it feels, how much swelling there is, how much pain there is when they're trying to work on their range of motion. And I think those metrics have been improved because we need to see less as a surgeon because the machine sees more. And part of the soft tissue stripping also involves protecting the ligaments so the surgeon inadvertently doesn't injure them. Here, the robotic arm creates those boundaries that Dr. Morwood had talked about. So by creating those boundaries, the saw blade cannot inadvertently get into those soft tissues. So therein lies the solution to this problem, because we don't have to pull and aggressively get things out of the way in order to gain access to the joint. So to some extent, I feel as at this point, the cases are predetermined or pre-selected. That's probably the better word, because we know going into it, we're not going to make these crazy adjustments until we make a decision of what the knee is actually doing.
Hello. I am curious about the use of the robot itself. It has an arm with a probe or a tool. Is this tool exchangeable so that different tools are used, or is this a universal tool that does all the work that you need to do for the operation?
Yeah, I can talk about that. Sure. So the arm itself is, here's a clinical photo of it, and it depends on what the operation is. So if it's a partial knee replacement, here's the tool that we use for the partial knee replacement. It's a burr. If it's a total knee replacement, it's a saw blade. So you just swap this out. The arm stays the same, but the saw blade comes in. And if it's a hip replacement, the saw blade comes off and what's called a reamer goes onto it. So it's a cylindrical shell where you mill into the bone. So yeah, it's interchangeable for what you need to use it for.
So this robotic device is customized for this particular type of operation, either knee or a hip replacement. How does that compare to other robotic devices, such as the Da Vinci, that have multiple arms with various probes for vision, for cutting, for sewing, and so on and so forth? This seems to be a one arm, one action type of approach.
So it's the concept of Da Vinci robotics is completely different than orthopedic robotics. When you're doing something on the Da Vinci, you're sitting at a console. You're not in the surgical field, and what you're doing is you're manipulating these arms that help you get at different, very difficult angles if you were doing them in an open or an endoscopic procedure. Robotic assisted surgery on the orthopedic side is a little bit different because you need, at the end of the day, you still need to make the cuts at certain angles, and you need to make a determination of how much bone that has to be resected. So the procedure has to be performed at the site. So from a technical standpoint, there couldn't be more different. The other scenario is that there's no comparable robot to what an orthopedic robot can do. Conversely, the Da Vinci can be used for any soft tissue procedures because it's essentially a clever suture passer, so it's a little bit different.
And the other thing too, one of the really nice parts about the orthopedic applications of the Mako is the preoperative plan. There's no preoperative plan in a Da Vinci. If you're doing a hysterectomy, for example, or an appendectomy or something, there's no plan. There's no way to go in and say, this is exactly what I want to do. And then the machine will only allow you to do that. In orthopedics, that's the nice part. We're able to ask questions first and then shoot, rather than shoot first and ask questions later, because of the preoperative plan. That's I think one of the nicest benefits to it.
So that's how you call it robot-assisted surgery, because it is the robot and the surgeon working together on the patient and performing complementary tasks on the patient, unlike the Da Vinci and other similar devices. Are there other examples of robotic surgery or robotic assisted surgery for other types of procedures that you are aware of that have been developed? Mako seems to be custom fit for orthopedic surgery. How about other types of surgery? Are you aware of other robotic devices that have been custom made for those procedures?
I think neurosurgery has something where they use something called the brain lab, where they're able to navigate certain segments of the brain. But to be honest, I'm not familiar with some of the other fields besides that. Are you?
Yeah, I mean, there's other general surgery applications, people doing gastric bypass and things like that. A little bit more of an application similar to the Da Vinci. In the trauma world, I know when I'm doing things around the, complex 3D stuff around the pelvis or around joints and things like that, we can use navigation, which is a little bit different, but it's a little bit more of a kind of real-time 3D scan. But yeah, I don't know any other.
So I'm not sure if the technology to synthesize and replace cartilage exists or could exist in the near future, but could you perhaps comment on the potential for something like that to be preferred or as opposed to an actual hip or knee replacement, or are there other factors that might require an actual replacement?
It's going to put us out of business. No, just kidding. There is a tremendous amount of research that's going into looking at that. Again, to usually step back for the analogy from trauma standpoint, when you have a fracture that goes into a joint, when there's joint damage, we know that kicks off some sort of inflammatory cascade that we can't quite yet modulate. So when you have a fracture that goes into the joint, we know that increases your risk of developing arthritic change down the line. So there's some studies that are looking at how do we modulate those inflammatory reactions, how do we try to mitigate those detrimental effects to cartilage. And then there's also cartilage regrowth procedures that are being tried. There are some moderately favorable results in younger folks, but that's more of the indication for that is contained smaller defects. So if you have an injury where you're playing basketball and you ding a little 5 millimeter area of cartilage that has a very contained, finite spot, there's things that we can do sometimes to plug that area or try some different modalities. When you have wear and tear arthritic change, especially change that you can see on an x-ray, where the cartilage is all gone, the bones, your body's making bone spurs to limit the motion of that joint to try to make you feel better, when the tissues around the joint are thinning out and weakening and the muscle is atrophying, there's no science yet to kind of either stop that or bring that back.
Suppose we did have the technology to synthesize and replace cartilage. Are there other factors that would still require replacement, like you were talking about fractures or something of the like?
I mean, I guess it's theoretical. Right now, the biggest thing is, I use the example for the hair and the skin. The reason why your hair can grow and the skin can mend a cut is because the blood supply is still contiguous to the area of injury. So the daunting feature of cartilage damage is that there's two problems. One, the blood supply is not viable, and so when it's injured forever. Two, we have yet to figure out a way for stem cells to differentiate into cartilage of greater than probably a centimeter at most. Therein lies the problem. The issue is most people, unless if they have had a specific acute injury, as Dr. Morwood has described, will not necessarily feel pain from a 1 square centimeter loss of cartilage in the hip, knee, or shoulder, or ankle for that matter. Most people present much later in the game. So I just think that I'm not so sure we'll see it in my generation. I mean, perhaps my kids' generation will have something available, because right now, it's, that's the $1 million question, I guess, on how do you get cartilage to grow when there's diffuse loss everywhere. And it's probably going to I'm going to guess, I have no evidence on this, but the current papers, they can't even simulate it in lower animal models. Yeah. So we're probably looking at 30 to 50 years would be my guess, but you never know.
Thank you.
If I use the mic, can I stand over here? Okay, good. Yes, so I do the posterior approach, I do the anterior approach. There's risks and benefits to each. And what I would tell you is it's a case-by-case basis. And I'll do the safest operation that's going to get you the best outcome. And then you say, basically the long and the short of it is the wound healing from an anterior approach can be challenging in certain people. The technical factors that with certain people who have either dysplastic or dysplasia of the bones can preclude a safe anterior approach. No, that's not one that is a contraindication. That's totally fine to do an approach from the front. But certain factors that will, again, case by case basis, is a discussion to be had, and then certain factors just you got to do the right operation for the right person for sure. Great. Well, thanks for Yeah, thank you, everybody, so much. Thank you.